Uh, Good morning, everybody. Thank you all for joining us today from around the world. I'm thrilled to have you all here today, and I'm very honored to introduce such a stellar panel to you all today. And they are here representing people, their countries from all over the world, as well as here in Cleveland. And they're here to share with us their experience in the management of this pandemic as an evolving public health and novel clinical entity about which we are still learning. I did want to introduce a couple of our sponsors that have made this possible. Platform Brewery, Downtown Cleveland Alliance, Supply Side Group, Ulmer and Byrne, Rotary Club of Cleveland, Eaton, Taiwan Sister Cities, Council of International Programs USA, Margaret Wong and Associates, Team NEO, Peace Corps, and 12 Literary Arts. So thank you for that. My name is Prakesh Ganesh. I am a family and public health physician here at Case School of Medicine. But prior to this, I was living and working in Malawi in Southern Africa for the last 4 years, while I was primarily doing HIV and TB work. I was recruited to come back to Cleveland right before the pandemic started, and I was quickly repurposed to help lead the response at the Cuyahoga County Board of Health. I want to take a minute to thank our panelists and introduce them. I will introduce first, I guess, Dr. Gordon and Dr. Liu, since I see them here. Dr. Gordon I'm also here in Cleveland, and Dr. Gordon is here in Cleveland representing the Cleveland Clinic. He is a chairman and staff member in the Department of Infectious Disease and a staff member in the Transplantation Center. He is boarded in internal medicine and infectious disease, and his interests lie in healthcare infective endocarditis, and cardiac device infections. He is a member of a number of organizations and has many leadership positions, but more recently, he was appointed to serve on the Defense Health Board, which serves as a federal advisory committee to the Secretary of Defense. Coming from Taiwan, we have Dr. Daniel Liu, who is from Taipei Hospital. He is a consultant and has served as an acting department of head at Pingtung Hospital, the director for health division for the Taiwanese Ministry of Health, and representative to the US. He's also been the director general to the Public Health Bureau of Taitung County and director of Pingtung City Health Center and the Department of Health representatives to Africa as well. Are the other panelists on now? And thanks. I don't think we overlapped, Dr. Liu, when you were in Malawi. And then we have Dr. Loubet Unyenje, pronounce that correctly. He is an orthopedic surgeon from the Democratic.
Ok, je suis là déjà.
Democratic Republic of Congo.
Hello.
He is trained all over the world, obtaining his degree in the DRC, residency and fellowship training in France, and further training in orthopedic traumatology in Morocco, with most recently getting his PhD in clinical epi in Morocco. And now he's working for HJ Hospitals in Kinshasa.
Hello?
And has Dr. Bock available?
Okay,
I'll just introduce him. He is an anesthesiologist and head of the department at Merano Hospital of the Department of Anesthesiology within the province of South Tyrol in the north of Italy, where we know they had been hit pretty hard. He focuses in patient safety and pre-op prep and risk management of surgical patients. Welcome, Dr. Bock. And he has an academic appointment at Paracelsus Medical University of Salzburg. Thank you, guys. Sorry for all the technical difficulties. I know I want to thank all the audience members for joining today. We'll be trying to answer all your questions. So just put them in the chat box if you have questions, and I'll try to go through them as we go along. And I'll open up to questions around 10:15 or so for everybody. Okay. I know a couple of people have presentations, and I was gonna let them share those to kind of help set the stage for where they were working. So I was going to start with Dr. Bock. He has a presentation on the job safety during enlarging an ICU for the pandemic.
Do you hear me?
Yep.
Okay, so I try to start the presentation.
Go ahead. Is it?
Okay, do you see the presentation right now?
No.
No, so. Okay. Now you see me. So share. Okay. Do you see the presentation right now?
Yeah, I do. In another
Okay.
screen share.
So we go into the presentation mode. Good afternoon here in Europe. Thank you for giving the opportunity to participate at this Congress. And I would like to talk about on-the-job safety during enlarging an intensive care unit for the pandemic. So let me please start with a description where we are. We are living in the province of South Tyrol in the northern Italy in the Alps. And our public health care system has 7 hospitals, the Central Hospital and the Merano Hospital, which you see encircled in red. And we have a ICU which offers 9 beds for patients with mechanical ventilation and a 3-bed intermediate care unit. So what happened? On March 6th, the local healthcare system decided that our ICU would be the referral for intubated COVID-19 patients. One day after, they performed an evacuation of all the non-COVID patients. And on the evening of this day, which was a Saturday, the first patient arrived. Monday, we saw that 9 beds wouldn't be enough, so we decided to enlarge the ICU to a 16-bed ICU with full equipment for mechanical ventilation. So we had to make some adjustments, which were done within 2 days. And on March 11, the reconstruction period finished, and we had the large ICU open. The question was, how could we do that in 2 days, and what were the major problems? At the beginning of March, we were confronted with a largely unknown infectious diseases, which had a rapidly growing number of critical inpatients. Nobody knew nearly anything because there was only evidence from China and some other hospitals from the north of Italy. But we also had to continue treatment for emergent cases, for obstetric cases, and for oncologic cases. The great problem was dealing with a team, because many team members were concerned about their personal safety, but they were also concerned about the safety of their families. So there was a lot of fear and distress. And if we put it all together, there was the workload and the psychological stress of this emergency crisis. We found some points later on in May when this publication was presented by British Medical Journal Quality and Safety in Healthcare, which give you some overview. There's uncertainty or doubt of the success within a team. There's the presence of inconsistent mental models, and attention might narrow. There's insufficient monitoring of the team. There might be vigilance and backup. And many have discomfort with speaking up. This might lead to psychological safety. Again, the risk of narrowing attention, over focus on oneself, which might produce reduced vigilance. The consequence of all this may be the development of a low team resilience and the danger of setbacks. So how to cope with this? The first thing that we thought would be crucial to involve the whole team. To involve the whole team in the planning of the specific ICU organization and of the execution of all the measures concluded. So for the team, we decided to perform daily briefings and debriefings. We defined a treatment protocol which was regularly improved when there was new evidence. We tried to have easily accessible information management, which was always up to date. We created a handover sheet for the patients, and which was very important. We had a constant exchange with the hospital management and with the technical department, so we could immediately adapt our ICU to the needs. We tried to minimize handovers and had 12-hour shifts, but we tried to make the break times as flexible as possible, and we constructed additional break rooms. This is because the personal protection equipment is very hard to wear, so if there was a team member who was exhausted, he always had the chance to recover. And we saw that all our work was appreciated. You see what happened at Easter. Look at the chair and look at the Easter egg. The population of our town gave us presents just like that. So what did we do for structural adaptions? Again, for structural adaptions, we involved the whole team. We defined clean and contaminated zones within the ICU. We used only equipment which was easy to disinfect. We tried to construct, and we succeeded in that, hyperbaric zones within the contaminated areas, so the spread of virus was reduced. We clearly defined the entrance and the exit gates, and we established special routes for patient transport and for the transport of all the material. Another thing, we tried to avoid transport of patients, and we tried to execute all the medical procedures on a bedside mode. Here's one example. You see the elevator which was reserved for COVID-19 patients. It was not allowed for other patients or staff members to enter in this elevator. And you see how we marked on the floor the entrance for the crucial areas. This is the sign which shows the entrance of our ICU. The outcome. At the end of April, we discharged the last patient, and on April 30, we started restoring our ICU to the original setting. In all this period, almost 2 months, we had a very nice team spirit. Nearly all of the team members said, this is our ICU. It was no longer the ICU of the hospital, it was our ICU. And we felt a real teamwork during the period. During the month of May, we performed a screening of 122 team members for antibodies against COVID-19. And we saw that in this period, only 2 out of 122 team members, which would be 1.6%, had developed antibodies. So we conclude that with our idea of working together and designing together the new ICU, we could also provide a great on-the-job safety in this very dangerous period for our team members. Thank you.
Thank you, Dr. Bock. That was very interesting to hear you share about your team building and your rapid adaptation of new guidance. I feel like that has been a skill that we've all had to learn over the last couple of months. We'll come back to you for further questions. I'll just turn to Dr. Onyenje, who has a presentation from the DRC. Is he with us?
No, I don't think so. He lost his connection probably.
Okay. So we'll come back to hopefully have his presentation so he could set the stage for the DRC. And is Dr. Gordon with us still too?
I'm back.
Okay, welcome. Dr. Gordon, I wanted to turn to you for the next question. After Dr. Bock's presentation, he kind of laid out some of the challenges that he's had with keeping staff safe, maximizing limited resources, and challenges with the public response. Can you walk us through kind of what you've had to deal with in the last several months and how you've helped to deal with these issues within our own community and institution?
Yeah. So thank you, Prakesh. And it's just a pleasure to be on this panel and learning. And Dr. Bock, I will tell you, is that we were on the phone with our colleagues in Italy, watching what was happening in obviously northern Italy with a lot of trepidation. And our hearts obviously went out to you and your team and all the people there. But it also, we had a little bit more, I suspect, of a little bit warning in the Midwest. As Prakesh knows, New York was hit extremely hard, obviously. As well as Boston, and we had a little bit of a lead and a little bit of what I would say learning from our colleagues. One thing we know, I would say about this is, first of all, we've learned humility. I think we approach this new pathogen with a lot of trepidation and a lot of respect, and we're all still in a learning phase. And early on, as we know, as was described, it was stereotyped as an acute respiratory pneumonic illness. We know that clinical evolution has evolved to things that have nothing to do with the respiratory tract. But again, our focus, like everyone else's focus first, was on the potentially handling that wave of the sickest patients. So the patients that would require intensive care, respiratory support, with this infection, as well as our other patients without COVID. And so this quickly became, I think, an alignment in learning from one another. And what we kind of all did was look at the experience, and we broke it down really into the 3 S's, we'd say, right? Staff, which is personnel, some personnel retrained, stuff, which is talking about ventilators and in PEP, and then space in terms of how are we going to, as was described, in terms of looking at how the, to keeping what we'd say in people that are suspected or not suspected, remind you of a little bit of the old pediatrician rooms, the sick and the non-sick. We've learned and we've evolved. Fortunately, with our healthcare system and with learning from colleagues, we never faced that moral dilemma from a clinician where, do you put someone on a ventilator or not on a ventilator? But I will tell you is that the modeling, as you know, Prakesh, we were ready to stand up convert our medical education campus into the Hope Hospital, like many other cities stood up, and most of those were not used. But I think going back to the patient safety aspect and the healthcare provider aspect, as was articulated, one of the biggest, I think, sequelae of this has been the mental aspects, the burnout, the fear, the depression, and also the stigma.
Madame, Steven qui parle.
Go ahead, Dr. Gordon.
I'm sorry. And so I think, it's interesting when a healthcare worker gets COVID, sometimes there's anger, sometimes there's guilt, and sometimes there is, well, what did I do wrong? And I think all of us evolved in terms of learning more about how this virus is transmitted, when it's transmitted. And most of us now have evolved to what we call something like a universal pandemic precautions. It reminds me of the bloodborne pathogen for those of you obviously a little bit younger, but we just assume now every patient in our hospital, and to be honest, healthcare worker, is harboring a respiratory virus. And that has informed us now for what we would call mask and shield, aside from obviously testing all our admissions now that we have testing capacity. But that has really helped us. And as you know, and I think as Matthias Bock can describe, the challenge in Italy was you assume you're a healthcare worker and you get COVID, that you got it from work. With community transmission, we know the biggest risk factors for our healthcare workers is actually outside the hospital. And similar to other studies, about half of our healthcare providers with COVID had someone else in the household with a COVID-like illness. And that also informs us outside the hospital setting to what we'd say in Massachusetts, mask on, in terms of this, and trying to do the same type of prevention, non-pharmacologic activities that we do in the hospital and in the community. Because as we all know, vaccines may be coming, but they're not going to be coming, how can we say, to provide herd immunity by Christmas. And we are going to be without herd immunity, without really good effective treatment in terms of prevention for quite some time. And therefore, the focus really is on human behavior, which I think Dr. Bock can comment now. I think Italy right now is kind of the darling of Europe in terms of COVID transmissions, in terms of lessons learned. And that's something I think in America that we are still somewhat struggling with.
Thank you, Dr. Gordon. No, that I feel for that response, being here in Cleveland as well. Dr. Bock, did you have anything to add to what Dr. Gordon had said?
I totally agree. Now we don't know what will happen. At the moment, it seems that we are in a rather good position when we compare to the other countries in Europe. Maybe because it was so hard here, we paid more attention compared to England or compared to other realities. So it's a strange situation. We all don't know what happens in winter.
And in terms of the behavioral aspect that Dr. Gordon laid out, how has things kind of changed in Italy there? I don't know if you heard Dr. Gordon when he spoke about Italy now being the darling child of Europe in that regard.
I don't know what we are. At the moment, it looks pretty good compared to others, but we know that things can change rapidly. There's a small country, Austria, north of us, which was always better than we were, but now things change. So I think the real problem is the fact you always have to go ahead. You have to face any new problem, and you can never retire. You can never go to vacation, or you always have to work on. And maybe when there's the vaccination, we can have some rest, but before that, we have to pay a lot of attention.
I want to turn quickly to Dr. Liu in Taiwan, in Taipei, and kind of on the same vein, kind of get an understanding of what they've had to deal with in Taiwan, especially with their proximity to China, to mainland China. I think you're muted. We're not hearing you, Dr. Liu. Does Dr. Liu have a presentation? Supriya, could you help out Dr. Liu? I don't know what's happening with him.
I'm not sure. Like either.
He's talking, and he's. I don't know if he's moving through this presentation.
I can call him and ask.
Okay, so maybe we'll go to Dr. Onyenje quickly. Dr. Onyenje, can you hear me? Dr. Liu, I can hear you very softly. Does anybody else hear Dr. Liu right now?
I don't.
Okay. And I'm not hearing Dr. Onyenje either. Okay. While we fix that, can I turn to a question to Dr. Bock?
Yes.
So in addition to kind of your adaptations in your hospital and on-the-job safety and maximizing the ICU, what has been in your experience kind of unique in Northern Italy?
Do you talk about our hospital or about the situation in Northern Italy in general?
I think the situation in Northern Italy in general as well.
In Northern Italy, we had the problem. We were the first Western country which went into the pandemic. So we had heard everything from China. We had informations about what happened in China, but we did not know what would come. We thought of a pulmonary disease, and later on, everybody saw that there was a pulmonary infection, but there was moreover another problem, the thromboembolic complication. So it's a systemic disease. It's not a pure pulmonary disease. And this was the great problem first, maybe from the clinical point of view, understanding what was going on. So this is the clinical point of view. And the other point of view is the point of team leading, how to deal with the problems and the fears in that situation, and how to move in a very quick manner, because you don't have time. It just runs over you. Now, when we know about the disease, we have more time, because we know that we can test patients and that we can separate patients, and maybe if there's a second attack from the virus, we will have less problems, because we can eliminate a lot of patients by testing.
And what were your limitations initially with PPE and testing capabilities?
I heard about Northern Italy that there were very great problems, and that they had to use PPE made by their own. We didn't have that problem. We were very lucky. We got equipment, and we always had equipment. So we were in a comfortable situation, but we were also afraid of lack of PPE, which fortunately did not happen within our hospital, but in other hospitals, I heard that it happened.
Dr. Gordon, can you share with us our experience in Cleveland in the similar situation, like our challenges with limited resources?
So I think, as Dr. Bock has mentioned, there was a lot of innovation. So when we looked at the ICU, and I think he mentioned this, all of a sudden we were able to put a lot of equipment outside the room, whether it's ventilators, dialysis, to avoid potentially exposures. Remember, at that time, transmission was still a question. And it's still a question, to be honest. This virus in general behaves like contact droplet, not like measles. On the other hand, we've learned for other situations, things can quote unquote aerosolize, or all of a sudden you can get high risk super spreader situations. But I think most of us had to do what we could do at the time that's pragmatic in terms of delivery of care. And I think we did a very good job of that. But we are still learning, and you're still going to get mixed messages. Remember, initially there was a focus that maybe this was Ebola, maybe it was more like a wet disease. You know, this focus on door handles and surfaces, which I don't want to dismiss completely, but that is not the primary means of transmission of COVID-19 in the hospital for sure. But I do think the other interesting aspect to me was the importance of aligning the testing, the clinical scenarios, and the fact that we did not have great treatments. And maybe Dr. Bock can comment on the exuberance to jump on clinical experience or anecdote. And I think a lesson we all learned here was the importance of doing randomized controlled trials, even in a pandemic, is probably more important, that we don't want to jump on the shiniest penny because that could have adverse consequences. And it is important that we do the RTCs, which can be done. In the States now, we're faced with the situation of plasma, which, as you know, was used early on by the Chinese. Some anecdotal evidence there, but as it turns out, probably limited effect in this type of pathogen in how it's being used. And yet 60,000 Americans has received plasma. And so I think we don't want to do harm. And from my own point of view as a clinician, we're still far away from a home run. Remdesivir also has not been an out of the park situation. The RTCs that we know really showed decreased maybe length of stay. Of course, remdesivir was probably used very relatively late in those situations. And I think as Precaution and Dr. Bock know, it's going to be used kind of as a cocktail, similar to potentially HIV with or without beta interferons or other things. But we still don't have that Tamiflu. We still don't have a post-exposure potential antiviral, and we may never get one. And then I think the other thing we're learning is transmission dynamics. So although that we focus on the hospitals, this, like other coronaviruses and respiratory viruses, it's burning in the community, within the households. And children, fortunately, don't get a severe disease. It's not that children can't get sick. We all know about the inflammatory syndrome, and the States published on 127 kids that have died, although most of those, interesting, were infants and died probably in the ER. But the point is children can certainly transmit. And if we look at our data now, similar to Europe, people with COVID in the United States in the summer, the average median age dropped 10 years, and that's being driven now by our college students and the young kids, 18 to 22, which now have the fastest increase of positive COVID testing.
Thank you, Dr. Gordon. I really wanted to get to the treatment aspect of this, so thanks for sharing that. Dr. Liu, are you able? Okay, yeah. I can hear you now. Go ahead.
The session. Thank you. I will then connect with my presentation right here.
Are you able to give your Could you give your presentation in about 6 minutes?
Oh, sure.
Okay. It's all yours.
Okay.
I don't see your screen. You had your screen up, but it's disappeared.
Sorry.
It's almost there. It looks like it's trying.
Yeah. There. Good. Okay.
There we go. Got it.
This is a medium-sized regional hospitals in Taiwan, where I work, which is the Ministry of Health based. And what happens is that when I have the hospital situated in the north, where 1/3 of the population stayed, we received the most number of visitors from mainland China from the very beginning. You can see from this presentation slide where it is located. You know, Taipei City metro area has a huge population, up to about 7 million people, about 1/3 of the population here. And our hospital is not huge, but luckily for us, we are also well equipped. And as of the day before, on 27th, we have total case reported, suspected case reported 92,000, and where 91,000 being excluded, and only 510 confirmed, which is quite minimal, especially noting that there's only 7 deaths. And total tests conducted is only 187,000. Considering, I know it's quite small number with the comparing to other country. So this is the graph showing that the cases being congregated around the earlier part of this year and kind of flattened out after June. And the confirmed cases also localized within the first quarter of the year. And ever since around May, we don't have any local cases except the imported cases. And this is how things are as of last week. And we have 149,000 persons tested. And this is the current regulation for the inbound travelers at the border and the community. I think this has been the issue being addressed quite much, because people are wondering how Taiwan can manage to stop infected carriers or patients entering Taiwan. And we need to continue to do so. And this is the current regulation, where negative PCR results are needed within 3 days before Taiwan. And at the border, we also check again those with symptoms, and they will be quarantined. Those without symptoms, they can have the home quarantine set up and report to the health authority through the messaging system. And we also continue with the IT tools, which I will explain later, like a bi-directional messaging system, monitoring, and the instruction for medical indication if there is a sign and symptoms. And these are the number of visitors recently from the neighboring country in this region. Notably, we still have quite a number of travelers from mainland China. This is between June and July. Taiwanese returning from mainland China amounts to 80% of the population of the passengers on the flight, whereas non-Taiwanese only comprises 13%. And Japan, Philippines, Thailand, and Malaysia, which amount to 1,000 to 3,000 respectively, according to the figure. And we can see the positive cases are so small that that show that the cooperation with this kind of setup being quite successful with bilateral and multilateral agreement in how to make sure that the infected persons are not crossing the borders. So that you can see, out of all these visitors coming to Taiwan, the positive rate is only 1,000, 0.08 per thousand. That's very, very small. So the hospital is actually quite well defined as part of the designated epidemic response hospital for the national and city network. And quite well structured is the command structure that is unified top-down, where messages and information are shared across at the same time, vertically and horizontally, which I'll put it that way. And interestingly, for the execution of the work that we do is quite well coordinated with the City Public Health Commission, like resources, the important resources like PPE, mask, disinfectants. Even we share the number of wards available by the minute through the internet, the connections, and the specific software. And unified resources request, if we ever need it, at the city level, is being done at city level, which will be extended to central level regularly when it's needed.
To
show
minute,
how
Dr.
our
Liu.
hospital works.
Sorry.
Okay. I should just show the picture here of the gate, thermal scan, and the floor for the workflow for the suspected cases, and the ER and the isolation room, and how we don the PPE. And this is how we stock check the important resources. And we even give free masks to special cases like on-call chemotherapy, tubic, as well as the hemodialysis patients. And not, of course, not all inbound travelers are tested. I think this is quite interesting, but I'll leave the notes for you to read up a little bit because the risk level are being different and we don't test everyone, okay? So the main messages are, we need to have unified command vertically and horizontally, and we need to build trust for the public to the technical bureaucrats. Clear and unambiguous messages to the public are vital. That's done by our Minister of Health, Chen, directly. And we need to also to get the most important evidence-based approach and full use of the past experience, like what we had for SARS 2003. And as you know from some of the news, the IT-minded approach is also very important. And the full cooperation, even from, especially from the minister level, Minister for the Information, Ms. Tan, and the mass stock check and travel information are also used with the app and the software. NHI, IC card, our national health insurance, for example. And we have very good rapid public and private mobilization for key medical resources, and very well known to for the masks, where we ramp up for 2 million masks a day up to 20 million a day at the current level. And of course, not forgetting, we have support from international friends and to friends when we are capable. And we can try and help as much as possible, and believe us that we can conquer COVID-19 together. And thank you for your attention.
Thank you, Dr. Liu. That was very helpful. I have a few questions that I'll hold for now, so I can turn to Dr. Loubet Onyenje to present his presentation.
Okay.
Elizabeth, can we project his? And same, if we can give him 6 minutes. It might be a little longer if he needs a translation, though. I don't see any questions in the chat from the audience, so unless I'm missing it, but so I think we have a little more time. But I did have a few questions for all the panelists.
Ok, Dr. Loubet, vous pouvez parler, je vais traduire.
Go ahead.
Can you guys hear me over the audio? All right. Dr. Loubet, on est parti. Vous pouvez parler. Hello, everyone. Thank you for having associated me on this panel for COVID-19. I will describe a few facts about the COVID-19 response in Democratic Republic of Congo. I thank the organizers for having associated me. COVID-19 is a difficult task in RDC. It is a medical, political, and ecological crisis. In RDC, it is the worst crisis that we have seen here. all of our living style has changed and inequality have arisen. One of the consequences is that this disease will spread. COVID is not just a change in time. We're asking ourselves questions. The question is the COVID spread the same in all the provinces of RDC? Are Congolese accepting medical care? And has there been similar diseases in RDC? And after this initial control of the disease, can we fear a second outbreak in RDC? And so we will cover what is going on in RDC with regard to COVID-19. The first case appeared on March 10 in RDC. And the head of the state has taken measures and regulations to stop the spread of COVID. Which are similar to the worldwide response. The question we are faced with now is on an epidemiology and is on a disease level.
1 minute, Alex.
Ok,
For Dr.
Dr. Loubet, on a plus qu'une minute. On a plus qu'une minute, donc il faut passer aux conclusions. Je pense qu'il faut couvrir les conclusions maintenant. Ouais. So since between March and September, there are about 2,000 confirmed cases, which is about 0.01% of the population. And so they are trying to study why the death count is so low and why so few people have actually been infected by the disease in RDC. There are a few answers. The first case was actually from travelers from Europe. And so the COVID was brought into RDC. And with regard to death count, the death count is 0.06%. And it's actually travelers. It's actually travelers that have had a higher death count. The people that did not travel and were infected had actually a low death count. And we have a few explanations for that. Firstly,
Dr. Unyanjik, sorry. I think we're going to I will have one more question and I can start with Dr. Unyanjik.
Okay. Et on va. His last point was that because everyone is taking malaria treatment every day, all the time, they suspect that this might help stop the spread of COVID. Docteur Loubet, maintenant on n'a plus de temps pour la présentation et donc il y a juste une question qui va vous être posée. Okay, Prakesh, I'm ready for the question.
So I'll go to Dr. Unyanjik and then Dr. Gordon, because I know Dr. Gordon has a hard stop. And I kind of wanted to share, kind of like, we have representatives from all over the world right now. And I kind of want to see what the goal of a lot of this meeting was, to learn best practices from each other. And so I wanted to know, what do you see your institutions doing in terms of collaborating to manage this crisis with other partners in the region or outside the region? And has Dr. Gordon had talked about that with Italy briefly. And has your institution already collaborated with others outside of your institutions to kind of share best practices?
Donc la question c'est est-ce que votre institution et votre hôpital a mis en place des programmes de collaboration avec d'autres institutions du pays et d'autres institutions dans le monde entier pour partager les bonnes pratiques?
I'll give you each a minute to respond.
Et on a une minute. So we have an institution that's in charge of pandemics, including malaria and Ebola. And so we have an institution in place that is in charge of communicating all through RDC. Oui, vous pouvez ajouter un dernier élément de réponse si vous voulez. Oui, c'était bon. C'est la réponse à la question. Yeah, so they say that they're already practiced with Ebola and chikungunya, so they have in place a pandemic response.
That was going to be one of my questions for Dr. Onyenje, because I knew they had gone through several pandemics. I wanted to know what kind of infrastructure was there. Is it okay if I turn to Dr. Gordon next?
Yep. Well, thanks, Prakash. You know, my thoughts on this are really, what are we going to do to prevent this from happening again? We're in a global environment. This has also taught us that in the age of supersonic travel, there is no fortress homeland. If something happens in one part of the world, as you all know, the surveillance, detection, and then intervention is so important. And there will be lessons learned. The other thing that I think we all realize is, look at now what's happening globally. Food insecurity, lack of other immunizations being affected because of COVID-19. This is having a huge amount of effect on global health, not to mention, of course, the strain on the mental health aspects. So I remain positive, but I also hope that we're going to continue to invest. And as you know, Prakash, in Cleveland, we are trying to now stand up obviously a global enterprise down in Florida as a joint venture to work, obviously, with all the institutions in the world. And hopefully we are going to invest in the future in vaccines, in basic science for prevention and detection.
Thank you, Dr. Gordon, and I really appreciate your time. And thank you for joining today. I know you're going to jump off soon, but we really appreciate your expertise and time. Dr. Bock, please. Sorry, I think you're muted, Dr. Bock. I can't hear you.
Excuse me. I agree to Dr. Gordon. It's a challenge for the whole world, and we have to stand together, and we have to understand that we have to resolve the problem together. And there's no possibility to do it as only one country. The whole world has to stand together.
Yeah. Thank you, Dr. Bock. Dr. Liu?
Yes, thank you for the opportunity. Clinically, as a pediatrician, I have to complain a little bit that we are receiving much less patients last few months. I think doctors here in Taiwan can agree that mask wearing, hand washing, and social distancing, all three combined, make the most effective preventive measures for COVID. And we know that mask wearing has no solid evidence-based research yet, but understanding the transmissibility being slightly weaker than those highly transmissible diseases like chickenpox, influenza, things like that, the COVID-19 can be stopped. I think this is the lesson learned in Taiwan, that we managed to get these key resources right from the start. You won't be late for anybody in the world. If we continue to stress this mask wearing, hand washing, and social distancing together, of course, with other measures coming about, we are very happy to join them and like vaccines and things like that. But please do that and continue to do the most basic thing. It's difficult, yes, because some of us do not believe in mask wearing as well, but we need to adapt and adopt. Thank you.
Thank you. I like that, adapt and adopt as a closing. I really want to thank you all, the panelists today, for sharing your precious time and your expertise to discuss our collective work during the management of this crisis. There's still so much we're learning about the disease, and I really appreciate you all sharing your vast experience. And I wish we had more than just 1 hour to hear from each of you. I think each of you could probably take more than an hour to share kind of what you have learned. But I am very grateful for your efforts and look forward to the next step in this shared journey that we all are taking together. I want to thank Global Cleveland and the Cleveland Public Library for hosting, and our sponsors, Platform Brewery, Downtown Cleveland Alliance, Supply-Side Group, Ulmer and Byrne, Rotary Club of Cleveland, Eaton, Taiwan Sister Cities, Council of International Programs, USA, Margaret Wong and Associates, Team NEO, Peace Corps, and 12 Literary Arts. I really want to thank everybody for joining us today. I didn't see any questions, so I hope I didn't miss anything. But I wish everybody safety and health in the days ahead, and please take care. And thank you all for adapting to our virtual panel. I mean, we all have technical difficulties on every meeting, but I just want to thank you guys all for bearing with us and working through this. Especially Dr. Onyenje, I hope I didn't cut you off early. I really apologize for that. All right. Thank you, guys. I'll close the session now.
Everyone.
Thank you.